Moving on, I'm delighted to welcome our next speaker, Dr. Sajeesh G, who is a senior consultant and head of department at Neyar Medicity, Trivandrum, Kerala. He currently holds the position of medical director at the hospital. His key areas of interest include USD-guided regional anesthesia training and practice, pediatric and geriatric anesthesia. I now invite Dr. Sajeesh for his presentation on ERAs for joint replacement surgeries. Over to you, sir.
So, good afternoon. It's very exciting. One thing is sure, at the time of when I am talking, my talk is started, no one is sleeping. Because after Dr. Krishna's talk and his fan base support, I am sure all of us are alive. Second thing is that since after my talk lunch will be served. So even after my talk also no one is going to sleep. So let us start. And it's very exciting to come to Manipal again. 2002 I have been here with the workshop and all. And from 2009 onwards we are conducting workshops all over India. We conducted around more than 70-75 workshops we have conducted. But to be very frank, that was one of the best workshops I have ever attended, last 2002. Big hands to the organizers and Anita ma'am. And the advantage is that we conducted the workshop in a dissection hall. One side we have all the dissection specimens and anatomy people, they are demonstrating the cadaver specimens, and the other side we are doing the block demonstrations. And at the lunch break, anatomy friends are telling us that, sir, now only we realize that this quadratus lumborum and thoracolumbar fascia has got this much importance in clinical anesthesia. From the next year onwards, we will highlight to the students that importance of quadratus lumborum, and your friends, those who are in the juniors and the MBBS student, sorry that we introduce another tough topic, that is quadratus lumborum and thoracolumbar fascia. At our time, the crack nut, breaking the crack nut was the unconius and all. Now to unconius ask the very crack nut questions. So then again the quadratus lumborum come into picture. But so thanks to entire organizing team, come to my topic. ERAs for joint replacement surgeries. And I will be greetings from my hospital, so Neyar Medicity Hospital. And I will be discussing on 3 headings, that is ERAs for the society recommendation. That's a 2020 recommendation. It's available free on net. You can search there. There are recommendation and regional anesthesia technique related to hip and knee arthroplasty, a little bit of details and how I do. First we take it's okay. These are the recommendations. The strong recommendation for all the 17 characters are there. And regarding the preoperative, some of are in the preoperative, intraoperative, and postoperative areas divided. We will take one by one quickly. So in the preoperative optimization part, actually the preoperative patient education, of course, that is very, very important in a replacement situation. Patient is fully anxious. They are going to get a new knee or a hip, and they are worried about the pain, postoperative pain, how it is. They got a lot of information from their relatives or those who have done the replacement previously that it's very postoperative pain will be a big issue. So we need a thorough preoperative checkup, and counseling and reassurance is very important. So that is recommended. And the smoking is at least 4 weeks prior stop, avoid alcohol consumption, and correct anemia prior to this thing. And of course, the preoperative physiotherapy, low physical activity can be initiated by before doing the surgery, knee replacement. And those who are in a sudden, following a sedentary lifestyle, you can have some physical activity and all. then a multidisciplinary consultation and clearing the infective focus. But on a ERAS point of view, pre-physiotherapy is not recommended. It has not that much advantage on that. On fasting, of course, we all follow 6 hour and clear fluid 2 hours prior to surgery. I'm sure that all of you are following this. The 12-hour fasting is no longer used in any type of surgery. And carbohydrate loading is a new concept around 300 ml, 2 hours prior to surgery, 300 ml of 200 calories we can have. But ERA's point of view, it's not that much advantage. Of course, pre-anesthetic medication also is not recommended. Maintaining the normothermia, of course, the normal body temperature should be maintained perioperatively and postoperatively. That is recommended. Antimicrobial prophylaxis and skin preparations. Antimicrobial, no universal regime which is applicable to all centers, even no consensus on that. What kind of antibiotic? Of course, the institutional-wise policy, you have to get it. The drugs are mainly the cephalosporins like cefazolin, cefuroxime, vancomycin and teicoplanin. In combination, you can use it. Only thing is that 60 minutes prior to the incision, you should give the antibiotic, and the infusion should stop 30 minutes prior to the incision or tonic application. Preoperative bathing and chlorhexidine with chlorhexidine skin preparation, and now we have antibiotic loaded cements also. So the recommendation is that patient should receive systemic antimicrobial prophylaxis in accordance with your local policy. Postoperative nausea and vomiting, we know the high risk group, and we have a dopamine antagonist, serotonin antagonist, and steroids also. It's in a combination, either one or a combination of other drugs we can use. Anyway, PONV prophylaxis is recommended. In surgical approach and technique, no specific technique is recommended surgically, and putting the post-surgical drain is not recommended. Perioperative fluid therapy, neither the liberal fluid therapy or a restrictive fluid therapy is advised. Our nice 2017 guideline is this one. Only point is that electrolyte imbalance you have to be careful, especially the replacement surgeries of hyponatremia is another big issue. So you should be cautious on the electrolyte abnormalities, and you should be careful in a renal impaired patients coming for surgery. So they recommended that IV fluid should be used judiciously, and postoperative intravenous fluid discouraged in favor of early oral intake. Intraoperatively, the protocol-wise, the standard anesthesia, we all know that regional anesthesia is better. Plenty of studies are that regional anesthesia has got less blood loss and other early mobilization and all other things. But the modern anesthesia techniques like TIVA and newer anesthesia techniques, the both general anesthesia or a regional anesthesia is recommended. ERAS is not in favor of spinal or a regional anesthesia alone. Analgesia, paracetamol, NSAIDs or other selective COX-2 inhibitors are recommended. Your spinal opioids are not recommended. And epidural part, I am with Arpita that epidural is no longer recommended for replacement surgeries. Of course, in most of centers, many of us are using, if using a bilateral replacement, still many of us are using epidural, but I personally, I don't use, and even I put a bilateral adductor canal catheter. Gabapentins also is not recommended. Intraoperative, preoperative blood loss, we know that the tranexamic acid has got a good beneficial role. So it is fibrin degradation, stabilizing the clot, and fibrin degradation is produced by the plasmin, by the activation of the plasminogen. That portion, that step is blocked by the tranexamic acid, so it's an antifibrinolytic. So it's effective in preventing preoperative blood loss and reduce need for blood transfusion. It is associated, it's not associated with a major thrombotic even in a high-risk patients. we have a good studies supporting that, and dose is around 15 milligram per kg. Normally, in a routine practice, what we do is around 1 milligram IV infusion 15 minutes prior to the skin incision or a tourniquet release. Or some surgeons will infiltrate intraarticular with 1 gram, and the subsequent doses may be 1 to 2 doses or 8 hourly, and subsequent dose adjustments has to be made with renal function assessment. So the tranexamic acid is recommended. Tourniquet, we have even Cochrane reviews there, and other plenty of studies are there, and tourniquet does not have significant improvement or any effect on the postoperative recovery. So the routine use of tourniquet is not recommended. Urine catheterization, as in any other surgical technique in replacement also, urine catheterization, that the postoperative urinary retention, that's a pore, or routine urinary catheterization is not advised. So we can measure, now we have the ultrasound machine, and we can measure the postoperative bladder size, and with the transverse view and the longitudinal view, we can measure, and we can calculate the width, the depth, and height into 0.7, and some 0.7 is a broader term, some minor adjustments are there. Anyway, we can calculate there. 500 to 600 is the normal volume allowed, but there is a study supporting that around 800 ml is the threshold limit. Beyond that, you can put an intermittent catheter and remove urine. So again, the routine use of urinary catheter is not recommended. If put, take it out as soon as possible. Antibiotic prophylaxis, we know that. Replacement is notorious for the Overshaw's triad, venous stasis, endothelial injury, hypercoagulability, all are contributing on the replacement. So the American College of Chest Physicians, they have minimum of 10 to 14 days we have to give. And NICE also has got a specific recommendation for THR and TKR. And American Academy of Orthopedicians, they are much liberal on this aspect, that pharmacological or mechanical agents, and that duration is choice up to the physicians. Anyway, the patient, we have to, so the patient should be mobilized as soon as possible, and the post-surgery antithrombotic prophylaxis should be in accordance with the local policy. Cement implantation syndrome, I am not going into the details, it's not a part of this thing, ERAS protocol. So the local infiltration analgesia, this ERAS highly recommend local infiltration analgesia. Normal volume what we use is around 100 to 150 ml, 0.2% ropivacaine or 0.25% levobupivacaine. Adjuvants what we used as the ketorolac, adrenaline, clonidine, and dexamethasone. These are around 50 ml injected on the posterior capsule just prior to the implantation, and after the implantation, next injection, and 50 ml on to the subcutaneously on the skin incision. Duration what we will get around 15 to 20 ml, 20 hours actually. 12 to 15 is a normal duration we get. If you add a dexamethasone, we will get a good little higher duration. Catheter, most of the surgeons are not comfortable with the putting a catheter, not even internationally, not much literature supporting that. When the liposomal bupivacaine came, in a Western world is very much waiting for a liposomal bupivacaine for this LIA and all. So, but the literature's support is not that much. There's a mixed response actually. Some literature supporting this one, and the persons, those who are personally used, and the person actually you introduced the IPAC, that is the Sanjay Sinha, and current last year IORA we met, they are not that much confident with steady effects they are not getting with the liposomal bupivacaine. So the LIA is recommended for knee replacement and not for the hip replacement, and nerve blocks are not recommended as ERAS component. But I have got a disagreement on that, because we are looking only the early patient discharge only, but quality of anesthesia wise, there are supports for the LIA plus continuous adductor canal catheters. So why the pain after TKR is important? Because all the trigger, all the pain generating things are there in the replacement surgeries. We have a nociceptive stimulation, inflammatory factor, triggering the local ischemia reactions and direct nerve injury. So of course the central sensitization also is there. And the postoperative pain type-wise, even with the background pain at rest is a big issue, and pain on movement around 100 to 200% more intense than the pain at rest. So we have to address it. It's a very distressing situation. So in intraoperative analgesia, the block-wise, THR, we can have a suprainguinal fascial block and the pericapsular nerve group, that is a PENG. Of course, we can have a sacral plexus block. Then the TKR. TKR, we have adductor canal catheter. I'll come to that later. Hip and articular dermatomal innervation. We will come to the hip first and then the knee next. So the hip, the anterior and the posterior distribution innervation-wise, at the hip capsule-wise, the main nerves are the femoral nerve, obturator nerve, and the accessory obturator nerve supplies. But around 80 to 85% of the pain that the nociceptors are from the anterior capsule, Of course, the posterior capsule has got some, but it is very less in the sense most of the pain receptors, there are mechanoceptors in the posterior capsule. So as the pain management wise is not a major issue. Still, the sciatic nerve and the sacral plexus are contributing to the posterior capsule innervation. That is through the superior gluteal nerve, inferior gluteal nerve, sciatic, and nerve to quadratus femoris. So again, the hip innervation on a dermatomal wise is very tricky. You name a nerve that is there in the hip. So this is an anterior and posterior. This is tricky. But postoperative pain point of view, we can very well manage with a few blocks. That's the best one is PENG block. You put the catheter, ultrasound probe over the anterior superior iliac spine, just move medially, we will reach on the anterior inferior iliac spine. Then we can see the ischiopubic eminence there. On top of that, iliacus muscle and iliopsoas tendon is coming out. We know the psoas major muscle is the major hip muscle, hip flexor. It takes its origin from the lower vertebral body and transverse process and inserted along with the iliacus muscle in the lesser trochanter. As it comes at the site of this PENG block site, so already the iliacus muscle tendon has came out. So we can clearly see not the iliacus, psoas tendon has come out. So we can clearly see the psoas tendon inside the iliacus group of muscles. So just below that area, you will inject a local anesthetic of around 10 to 15 ml. That covers the femoral nerve, obturator nerve, even the accessory obturator nerve covers. That covers around 85 to 90% of the pain as far as the hip is concerned. The entire anterior capsule we can cover with this block. And you can see the femoral artery on nerve also is there. So that is a little away from that area. So there is no issue of lower limb weakness. So we can mobilize the patient. That's the motor sparing block. Another block is commonly used is a SIFI. That's a suprainguinal fascial block. You can see on the left side of the monitor, you can see the sartorius muscle is there. What we do is that at the anterior superior iliac spine, the transducer is placed craniocaudally so that the cranial end is directing towards the umbilicus. So then we will get a picture on the left side of the monitor that you can see the sartorius muscle. On right side is the internal oblique muscle. That shape we call it as a bow tie appearance. On top of the anterior superior iliac spine, this iliacus muscle and top fascia iliaca. Just pierce that area and give a. But the problem is that almost double amount of local anesthetic is needed there. So comparing the femoral and the fascia iliaca and PENG block, fascia iliaca we need a higher volume and there is a possibility of local anesthetic toxicity. But PENG is a low volume and the quadriceps weakness Of course, femoral has got a we can expect quadriceps weakness. Due to the high volume spread to the femoral nerve, and we can expect lower limb weakness. That's a quadriceps weakness in fasciileaca block, but in PENG it's low. And our target is deeper, so no major structures are there. And the only problem with the PENG is that lateral cutaneous nerve is not covered. So come to the innervation of the knee. Again, the knee is has got a genicular nerve, superior, and we have a superior, inferior, lateral, and medial. So we have a supralateral, infralateral, supramedial, and inframedial. Anyway, these are the major nerves: femoral nerve, common peroneal nerve, and tibial nerve. And posterior side we have obturator nerve and tibial nerve and common peroneal nerve. This is a nerve to vastus medialis. This is very important now as far as knee analgesia is concerned. When we'll come discuss it later. There is a good article on our WFSA regarding motor sparing block on knee. So the knee, we have an anterior knee. We can block with the femoral triangle or an adductor canal block. We'll discuss this later. Posterior IPAC, popliteal plexus block, or a tibial nerve block. Of course, LIA also is there. So come to the IPAC. This is the IPAC position. We'll keep the patient knee is flexed and externally rotated. And this is a femoral condyle, just lateral to the femoral condyle, just medial to the femoral condyle, and between the popliteal artery, inject around 10 to 15 ml. This is another view, that's a posterior view. And then come to the major block. Is an adductor canal block, and you can put the catheter, adductor catheter, and keep analgesia for at least 48 to 72 hours. So we have a proximal femoral triangle, that is also a proximal femoral triangle and distal femoral triangle. Then where actually the differentiation between up to which part is femoral triangle and below is adductor canal, that we can do it with ultrasound. This area, when it is carried, we call it as a fish mouth appearance or a figure of 3 appearance. It's muscles, so anatomically the muscles of sartorius and adductor longus comes. This area, 1 centimeter above that means this is a distal femoral block. 1 centimeter below means the proximal adductor canal block. The importance is that we want to catch vastus medialis. There is a very important nerve supplying we've got a better quality analgesia of the knee. So this adductor canal catheter, we can put the catheter. So the last part, how I do. So regarding the total hip replacement, preoperative education, counseling, pre-anesthesia checkup and all, prophylactic antibiotic, what we use is a cefuroxime and the sulbactam combination and teicoplanin. And intraoperatively, spinal anesthesia is the default thing. And if contraindicated, or our patient is little fussy, especially rheumatic patients and all young patients coming, we'll give general anesthesia. Then urinary catheterization is needed in most of the time because it's a hip procedure. And normothermia is maintained, and no liberal IV fluids, and tranexamic acid is given 15 minutes prior to surgery. And as a regular practice, we use a dexmedetomidine infusion intraoperatively as a sedation, because patient is in a lateral position and a very distressing position, and with the spinal anesthesia and all regional anesthesia, it's very comfortable with the dexmedetomidine infusion. Another advantage is that we don't have a facility to put a tourniquet and for reducing the bleeding and all. Dexmed give a good blood pressure control. Most of the patients are hypertensive and all old age patients. The postoperatively, what personally we use a PENG block with a 15 ml of 0.375 ropivacaine with dexamethasone combination. And if you give additional sacral plexus blocks, give an excellent analgesia. But the problem is that if you want to mobilize the patient earlier, we avoid the sacral plexus block. And injection paracetamol 8 hourly, and if ketorolac, NSAID, definitely we give. Only problem is that if any patient is contraindicated, like old age, hypertensive, diabetic, and the renal impairment is expected, so we will avoid. No opioid supplementation. We never needed an opioid supplementation. Again, the thing is most of the old age patients and all, most of them have a restlessness and ICU psychosis and delirium in the ICU in the first day, even in the first day. So the dexmedetomidine injection is a very good option for that. And early physiotherapy and thromboprophylaxis, why we use 30 to 40 milligram subcutaneous enoxaparin, later to rivaroxaban. And coming to knee, pre-op evaluation, our same, again the spinal is the default anesthesia practice. We avoid urinary catheterization here and intraoperative sedation, whatever the midazolam, fentanyl or dexmedetomidine infusion. Most of the time we use tourniquet, surgeons want tourniquet. The technique wise, we use an adductor canal, the IPAC 15 ml of 0.5 ropivacaine or tibial nerve block. Just after the spinal anesthesia, give a selective tibial nerve block to 0.5, 5 ml of 0.75, 0.75, 5 ml I personally give. If surgeon is not giving LIA, because we want to catch the posterior portion analgesia. If LIA is there, it's not an issue. But otherwise, you either give a IPAC or a tibial nerve block. And then we give if it is a LIA, is our cocktail is 80 to 100 ml and ropivacaine, adrenaline, ketorolac and clonidine. And postoperatively, I put a distal femoral or a proximal adductor canal to catch the vastus medialis. Okay. 0.25 ropivacaine and keep a infusion of 5 to 8 ml per hour with the fentanyl. The first day I will keep the fentanyl, that will patient will have a good sedation also, is comfortable there. And whenever the pain score touches the 4, give a bolus dose of adductor canal. And injection paracetamol or ketorolac, other things, and start oral feeds as early as possible. And the physiotherapy is the next point. Actually, the point is that most of the surgeons are comfortable with the LIA. They say that only LIA is enough, no need of adductor canal and all, but practically after 15 hours, patient have a good pain. The next day morning, they come for the rounds, patient is comfortable, okay and all. As soon as they move there, the physiotherapy team will come, they started doing the physiotherapy, then the pain comes. The pain, actually, most of the time we follow up, the pain even comes to 8 and 9, the pain goes on the first day. What I personally do is that 1 hour prior to the physiotherapy, if they come for a physiotherapy at 9 o'clock, at 8 o'clock we start a ketorolac injection, then a diclofenac, then a 10 ml of adductor canal bolus. At the time of your physiotherapy, never and ever the pain will go beyond 3. The maximum 1 or 2 will be the pain. And next evening also, if they want to mobilize the patient, in the next day morning, afternoon and all, we keep the patient to mobilize the patient and allow the walking and all. That time we will reduce the infusion, and next day after the physiotherapy, we will give an additional bolus dose. And never and ever at the first 2-3 days, our pain will go beyond 3. So to summarize, ERAS for the joint replacement, yes, but if earlier mobilization, the first day, second day, if you are mobilizing the patient or discharging the patient, but then practical point of view, even third or fourth day, patient having a 7 to 8 pain score on physiotherapy and activity. So what we personally do is, of course, we do some patients, with selected patients, we do ERAS, but in other patients, routinely, we keep the patients for analgesia, maintain the catheter for 72 hours at least, and give analgesia and all. Now, our physiotherapy team has got a little complaint about us that after third day, sir, you remove the catheter. After that, you have pampered the patient. After the fourth day and all, they are not, they want the injection prior to the physiotherapy and all. So anyway, that's up to weighing the merits and demerits, you decide. Thank you.
Thank you, sir, for the informative talk on the topic. I now kindly call upon Dr. H.M. Krishna to join Dr. Sajeesh on stage. The floor is now open for discussion to address any queries from the audience.
Dr. Sajeesh, that was a very nice talk. I have 2 or 3 doubts. The first is, you said you wouldn't give intrathecal opioids for either hip or knee surgery.
Yeah.
Why would you not give? Because that gives continued analgesia
No,
for
madam,
up to
even
24
without,
hours.
ERAS is not recommended. That is the thing what I
But,
showed is
would it
ERAS is not
not,
recommending thing. But I personally, I am also is not using it. Even without intrathecal opioids, we'll get a good analgesia with regional blocks. That's
I was just wondering, opioid doesn't add to any local anesthetic toxicity and is known to give 24 hours of analgesia, where pain is probably intense, particularly at the time of physiotherapy. That's one question. Second, you said even when you do bilateral knee, you don't put an epidural. Was that right, or was that incorrect?
Yes.
So, you 2 knees will be done in a spinal time?
Yeah, we do it in a single spinal anesthesia.
They will finish in
they will
that
finish
particular time. And the third question,
That time we will add
Adductor canal.
adding the clonidine, you'll get around 3.5 hours by the time they will finish.
Then we are talking about this LIA, and I don't know if you do bilateral knee and you do LIA. Have you ever wondered or kind of been cautious for a local anesthetic systemic
Yes, that's
toxicity?
what I personally do is that one side I give a LIA, other side I give a tibial nerve block. I need only 5 ml for the tibial nerve block. Only.
Okay. So, but the LIA has...
That is for the posterior. That is for the posterior analgesia.
Okay.
Other side,
And,
I'll put a bilateral adductor canal catheter.
Okay. I don't do so much of ortho for me to this thing, but these are the things that cropped up to my mind. And you made a statement that you would give dexmedetomidine as an adjuvant infusion for hip. Because of the lateral position.
Yeah,
but you would not need it for knee surgery.
Knee surgery is patient. Normally it's not enough. No needed actually.
Okay. Thank you.
Thank you.
Good afternoon. Thank you, Dr.
Madam.
SAJEESH, for your...
Madam.
Yeah, it was an excellent talk, and I learned a lot from it. But I just have... I'm glad that you told us what are the guidelines and then what you do, because as your guidelines said, you don't give epidurals, they don't recommend catheterization, etc. But these are guidelines written in the West, and as of now, I know that for knee replacements, it's same-day surgery and they're discharged home the same day for knee replacement. And that is one of the reasons why they do not do central blocks, etc. And you're giving all the other medications. Whereas in our setting, I don't think anybody gets discharged the same day. You are in the hospital, and therefore you have your technique of, as you said, putting in catheters even for 72 hours. So I think any recommendation that we do get, we always have to think in the perspective as where it is given. So we don't have to follow it to the T, because in our setting, we are not discharging patients the same day. I'd just like to make that comment.
Definitely, madam. Actually, to be very frank, the Western side, I'm sorry to say that comment on that point is that this is insurance driven. That is my take. Because as early as possible, they want to discharge the patient. They are least bothered about the patient care on the post-operative analgesia. But practically, even on the third day, patient is having 8-score pain actually. We have to face it all, these tough situations in our situation, in our country and our this. But I don't know how they have, that's how the liposomal bupivacaine, they were very keen on that because around 72 hours, good analgesia, at least for the 72 hours with LIA, they got a good analgesia, and IPAC also this thing. But according with our limit situations, and I don't say it is a limited situation, we are also in a good situation. We can provide at least around 7-day hospital stay, never and ever will touch more than 3 or 4 pain score. Of course, in the second day, all patient started walking or started we stop the adductor catheter and just walking and all pain score will go to 5 or 6 and all. Immediately after that, we will give an additional bolus. It's comfortable. It's comfortable. Yeah, please, madam.
You mentioned that for local infiltration, you use quite a, multiple drugs. You use bupivacaine, you use adrenaline, you use ketorolac, and is it dexamethasone or?
It's a clonidine, dexamethasone.
Clonidine, yeah. So I'm just wondering, how did you come to that combination?
No, madam. This is an accepted international cocktail.
With adrenaline?
Yeah.
Okay.
It's a cocktail most of us using. Okay. Actually, the using a dexamethasone will put a little bit of increased duration of anesthesia, analgesia. But the point is that most of the surgeons is not confident in adding dexamethasone with along with their intraarticular steroid and antibiotic and all.
Thank
And
you.
another thing is that those in higher centers, there's routinely using an ERAS. Actually, you should take a study on the patient coming for the second knee surgery. How was their experience on coming for the second knee surgery? Actually, in our settings, our patients is, if you give a 1 month date, they will come comfortably, they will come for the second surgery because they're confident that first surgery was absolutely pain-free and all. But I'm curious to see how about the ERA patient come for the second surgery, what they are. If they are happy, then that technique will work.
Well, thank you for the good work you're doing, sir. Thank you.
Thank you, madam.
I would now like to welcome Dr. Malvika to present the mementos to the speakers.
Have a case discussion on cleft lip and palate. The moderators are Dr. Nisha Sarah Jacob and Dr. Shruti Naik. Dr. Nisha is an associate professor in the Department of Anesthesia at KMC Manipal with expertise in pediatric anesthesia, resuscitation science, and medical education. Dr. Shruti Naik is an assistant professor at Yenapoya Medical College, Mangalore. The speakers for today's session are Dr. Priyanka, junior resident from Kanachur Hospital, and Dr. Indumati, junior resident from Yenapoya Hospital.
And would you like to just introduce yourselves before we start?
Good afternoon to one and all. I am Dr. Priyanka from Kanachur Institute of Medical Sciences, Mangalore.
And you're Dr. Indumati, is that right?
Good afternoon, ma'am. I'm Dr. Indumati from Yenapoya Medical.
Welcome. So this is a PG discussion. A cleft lip and palate is a short case that is often asked for your examinations. Can I request all the PGs to please come forward if there are any postgraduates here? Before we start, have you done cleft lip and palate procedures? Practically, yes. So I want to keep this discussion as practical as possible, and we'll discuss some of the problems that you can anticipate as we go along. Is that okay? All right. So this was the case that was given to you, isn't it? An 8-month-old infant weighing 5 kilos, obviously quite malnourished. Presents with a history of nasal regurgitation following feeds and poor weight gain. He's scheduled for a cleft palate repair. So, since this is a short case, we won't go into the significant histories and all. This is the final summary that has been given to you. Can you tell us what are some of the salient points in preoperative assessment that you want to ask about, which you think might affect your anesthetic management of your child? So I don't want things like, maternal infections in the mother, because that's not going to really affect. That's pointing towards an etiology. But relevant things that you want to look at and focus on in your pre-anesthetic assessment that are going to tell you that this is going to be a problem or not.
Ma'am, first of all, this patient is having a cleft palate, and he also has a history of nasal regurgitation. So that means that baby is more prone for upper respiratory tract infection due to nasal regurgitation, and also pulmonary aspiration is more common in this child.
So upper respiratory tract infection, like you very correctly pointed out, is a possibility. So how would you differentiate a child? Is nasal discharge common in these children?
Nasal discharge.
So how would you differentiate between an upper respiratory tract infection and, say, a nasal, basically an infective versus a non-infective pathology? Is that important?
Yes, ma'am.
Yeah, so how would you differentiate?
Baby usually can have upper respiratory tract infection with nasal discharge, but our concerns will be if it is associated with fever, if the baby is having excessive sputum production and the color of the sputum.
So all that is in history. In examination, what are the signs or signs that will point towards?
Congested mucosa and fever may be present.
Anything else?
nasal flaring and
Okay,
on
you're talking
auscultation.
about child in distress, respiratory distress, and concurrently lower respiratory tract signs, right? Wheeze and
wrong
crackles. All right. Anything else other than upper respiratory tract infections that you want to identify in this child preoperatively?
Nutritional status, whether the baby is malnourished or any anemic sign, anemia is present, or
Okay.
and milestones. I would ask for the specific milestones, whether it has reached for the
How is
perfect
that
age.
going to affect your clinical management of the baby?
It would tell that baby is also associated with some other congenital abnormalities.
So you are going to look for other assess for other congenital anomalies. So why are you interested in that?
Congenital anomalies are most commonly associated with a difficult airway.
Okay, so your second thing that you want to focus on is a difficult airway. Okay, right? What are the features that will tell you that this might be a difficult airway in a child?
Cleft lip, cleft palate, micrognathia, or large
So
tongue.
how would you assess for micrognathia in a child?
Mouth.
We have to see the side view of the
Yes.
baby.
Perfectly right. You have to
Yeah,
look
if
from
there is
the
any
side of
recessive
the child. That's
of
right.
the mandible, it is
Yeah.
considered as a difficult airway.
So all these will let you know that you can anticipate either a difficult, what are you expecting? Is it a difficult ventilation, laryngoscopy?
Mostly mask ventilation will be difficult in this patient, along
Okay.
with the laryngoscopy is also difficult.
Fine. Anything else other than URTI, difficult airway?
These babies are more prone for middle ear infection due to eustachian tube defects,
Okay.
and they will present as a chronic.
So
chronic
that
or
is
acute
part of the
otitis media.
infective etiology. So you might want to treat with a course of antibiotics following swabs and so on and so forth. That is the infective etiology that you're looking for. Anything else? Other?
Conductive hearing loss. along
Yes,
with
true. All that is part of rehabilitating the child at a later
Speech.
point. But what else for anesthetic management per se? Would you like to look for syndromes? Why are you interested in syndromes in these children?
Along with the difficult airway associated with congenital abnormalities.
What congenital abnormalities?
Cardiac anomalies.
Yes. So the main concern for us as an anesthetist is a cardiorespiratory system. Of course, these children can have neural problems as well, but as far as anesthesia is concerned, you are concerned about the cardiac, if there's an underlying cardiac defect in the child. So often in children, you may or may not be able to pick up on auscultation. Clinically, you may have to pick it up based on the symptomatology, or in many centers, we do a routine echocardiography for these children. What else? Anything else? How about features of, so if the mother says the baby has history of interrupted feeds, takes a long time to feed, has snoring at night, does that tell you anything?
OSA features are
OSA
present.
features, so that will again should be one of your points of focus in your preoperative assessment. Do you have anything to add in preoperative assessment?
Suppose when you go visit the child will have watery discharge of the nose. Okay, so you will, like you said, infective, non-infective. So for how long you'll wait if it is infective? For how long you have to wait to take the child for surgery?
Elective surgeries, 2 to 3 weeks, we can defer the surgery, ma'am, if it's active and can be treated with 1 shot of antibiotics.
Okay, what are the common syndromes associated with cleft palate and lip?
Most commonly, it is associated with Peary-Robin syndrome, Treacher-Collin syndrome, Down syndrome, Klippel-Fehr syndrome, and golden hair syndrome.
You should know the features of these syndromes.
If you ask me, I can never remember them. So that's a practical aspect of it. But you do need to know what are the features of it before you. Is it an elective procedure or not?
It's an elective procedure.
So you have ample time to prepare, right? So if you know that this child has certain syndrome, you need to be able to look up and say, okay, this is a problem that I can anticipate. Coming to the first condition that you named, Pierre-Robin sequence or syndrome, what is it?
Pierre-Robin sequence is one anomaly which is leading to subsequent anomalies.
So
Like,
what do you,
in Pierre-Robin
what do you
syndrome-
understand? What
Yeah.
is the difference between a sequence and a syndrome?
In Pierre-Robin syndrome, first a baby will have retrognathia, ma'am. That will leads to posterior displacement of the tongue, which is glossoptosis, which can cause an airway obstruction. This airway obstruction, to relieve that, baby will cry, and prolonged crying can cause exhaustion and cardiac symptoms.
No, so we are talking about coming back to the etiology. So syndrome versus a sequence. Sequence usually has a single underlying etiology. So in Pierre-Robin sequence, what is the underlying etiology?
Glossoptosis. Retrognathia.
So it is micronathia, which is the inciting problem. Because of the micronathia, there is no space for the tongue, and therefore it doesn't come down. So okay, because of that, it's positioned posteriorly, and therefore the palate doesn't close. So the single inciting etiological feature is the micronathia. But why the micronathia happens may be because of multiple etiologies. Okay, so in one baby, it may be because of temporomandibular joint that is not developing properly. In another baby, it may be because of oligohydramnios and so on and so forth. Whereas a syndrome, in every baby, trisomy will always be the same etiology. Just Down syndrome will always be trisomy 21. Okay. So that's the main difference. Now, you have done your preoperative assessment. You've identified problems in this child. What problems are you anticipating for the surgery? What are the main concerns?
One is the pediatric patient, that itself is a
Okay.
concern.
Okay.
Then difficult airway.
You might anticipate a difficult airway. Yeah.
And shared airway along with the surgery.
Shared airway, absolutely. Anything else?
Post-operative pain management. And
Pain management is a concern. Why is pain management a concern in this group of infants? Can you use your mic, please?
Cleft palate surgeries are usually more painful.
They are more painful. So what is your pain management going to be?
Multimodal analgesia, ma'am.
Yes. So in that, what are you trying to prevent from happening? Can you use opioids as you would for any other child?
No.
If not, why not?
These babies are more prone for post-operative airway obstruction.
So especially in children who already have features of OSA, they will be quite sensitive to the effects of opioids. So you need to identify this and tailor your anesthetic management accordingly. Added to that, remember that postoperatively you can have a new onset
Mucosal
obstruction because of the surgery per se. So you need to be extra careful, right? Right. Shared airway, we said. And anything else? Any other concern? Intraoperatively, postoperatively? Fluid management. What about bleeding?
Hypothermia, bleeding.
Yes, the incidence of massive hemorrhage is quite rare. Even so, because they are operating on a small field, they can have quite a large amount of oozing over a period of time. What about temperature management?
For hypothermia is expected.
Often it's actually hyperthermia, okay, because the whole body is covered. You will be warming the baby so much without monitoring the temperature. So the body heat may go up. That is also not good. So it is important to monitor the temperature, if possible with a core temperature monitoring. If oropharyngeal is not possible, is there any other way? Rectal is another possibility, yes. Right. Now you have done your preoperative assessment. What are you going to advise the parents about this? What can they expect? You have to take consent, right?
Yes.
Yeah.
Informed and written consent I'll take. Then I have to explain the NPO guidelines for the baby. So it will be 6 hours for the solids and 4 hours for the breast milk. 6 hours again for the infant on the non-human milk.
Okay. What about
And 2 hours
clear
for
fluids?
the 2 hours for the clear fluids.
What about water?
2 hours.
Okay, so you
But
can
recent
give
guidelines,
water
they
up
have
to
to
1
1
hour,
hour.
up to 3 ml
Up to
per
3
kg.
ml.
That's the current recommendation.
recommendation.
So you can give, especially if your child is ideally, this child should be high up on your list, but if it is down the list on a plastics case, you have to ensure that the child is well hydrated. Right. Anything else you want to warn the parents about?
Post-operatively,
Yes.
baby will have some mucosal edema, and to prevent that, they will tie the tongue towards.
So you have to explain to them that they can
Temporary.
expect that there may be a tube in the nose sometimes. Some surgeons will want to put a nasopharyngeal airway. You will have to warn them that they might have a tongue stitch in place. You will have to warn them that their IVs might be bandaged up, right? You will have to warn them, most importantly, that their child is not going to be the happy baby that they are going to give to us. Child is going to be a bit cranky, might have a little bit of oozing from the mouth, which is normal, but if there's excessive oozing, you have to, bring it to the attention of the nurses or the staff, right? Right. Anything else you want to add before you go on? Okay. Right. So you have induced this baby, and you find that mask ventilation is difficult. Okay, you've done a gas induction with sevoflurane, or rather before that, how are you going to induce this baby or bring the baby in from the parents? Do you have any plan in mind?
If the cannula is present, I would go ahead with
How are you going to secure the cannula for this baby?
I would like to apply EMLA cream, that is eutectic mixture of local anesthetic.
So
And
if
then
your
I would-
venous access is good enough and you've identified it, you can always apply Prilox or EMLA cream. At least, how long you do
30
have
minutes, 30 minutes to 45 minutes.
30 minutes is hardly enough. Usually you need at least 45 minutes, sometimes even longer, with an occlusive dressing. The area has to be marked well ahead of time and not, erased off by the nursing staff and so on. And then you can distract the child and put in an IV. That if that works, well and good. But always when you plan for an IV placement, you always have to plan for failure of that. So if that fails, how are you going to bring the child in?
Oral midazolam syrup.
So
or
you
pedicure
want to
assist.
give pre-medication. Is there a problem with pre-medication in these groups of children?
Chances of difficult airway is there, so.
So
better
if you
not to
already
give
have a
already.
child, if you already have a child who has features of airway obstruction, pre-medication can be a bit dicey, but if required, graded in graded doses and under monitoring, right? Oral midazolam, how long does it take to act?
15 minutes, 15 to 20 minutes. 0.5 mg per kg.
0.5 mg per kg. It takes longer than 15 minutes, at least 30 minutes it will take to act. Any other options? Now that you give it to the child and the child spits it out. Why does the child spit it out?
Flavor.
It's
taste.
quite bitter, okay? Children will often spit it out. So if that is the case, what are you going to do?
Can give pedicloral syrup or fentanyl lollipops.
Fentanyl lollipops, pedicloral. Pedicloral, yes, it's a fantastic drug if it works. But the problem is the duration of sedation is much longer than you want it to be. So, yeah. Any other options?
I am ketamine.
Oh, I am ketamine. The mother will throw you out. Any options before we go into invasive ones? So invasive ones are always the last things that you would want to. Nasal, yes, nasal. You can use dexmedetomidine or even midazolam. All right. Oral ketamine is another option if you have it, but that you have to be very careful because the child can fall asleep quite fast. So you need to be a bit careful about that. Right. Why do you need pre-medication?
Parental separation.
Yeah, parental separation can be a problem more for the parent than the child. Yes, the child will cry, but whether the child will actually remember this 2 years down the line is again debatable. Some do say yes, some no. So if you have a smaller 6-month-old child, maybe I personally would not, but a 9-month-old, 10-month-old, you may need some amount of sedation. Right, you have gas-induced the child, you've secured an IV, and as you're deepening the plane of anesthesia, you find that mask ventilation is difficult. What are you going to do?
Use a supraglottic.
Think of it in your own clinical scenario. You're in the OT. You've done your protocolarized machine check. You've sedated the baby. You've brought in the baby. You've gas-induced. You've secured a line. And because before you intubate, you either have to paralyze or you have to take deep on sevoflurane and give a little bit of propofol and intubate, right? So when you're trying to do that, you find that mask ventilation is difficult. And as we discussed earlier, you can have difficulty in mask ventilation. So if you find that problem, what are you going to do? What are your options?
Chin lift, jaw thrust.
First, I'll alter my positioning for mask ventilation. Some chin
Optimize,
lift,
excellent. Optimize your positioning for mask
chin
ventilation.
lift and jaw thrust can be given.
Yeah.
I'll
not worked. What do you want to do?
I will recheck whether my mask size is appropriate. For the
Mask
child.
size is appropriate. Anybody from the audience? Shout it out. Come on, guys. Oropharyngeal airway? Airway adjuncts. Oropharyngeal or a nasopharyngeal airway can be used, right? If that doesn't work, anything else?
Supraglottic airway devices.
Supraglottic airway can be used as an aid to ventilate. Anything else that you can try? You mentioned it in passing, but I need you to define it a bit better. What position can you adopt?
Burp.
Anybody? That is for the head and neck in the supine position, a shoulder roll, just because you have a larger head in the child. Often lateral position might help you. So you might need to consider changing the position as well if you are in trouble. And always, always remember that this is again an elective surgery. If you feel that the airway is difficult, get help in early, have your difficult airway cart. And if nothing works, if you think you're definitely going to land up in trouble, and if you think that your airway might improve with time, perhaps postpone the surgery until such time, okay? As is possible in a Pierre-Robin sequence, right? Okay. Are you expecting any problems with, we finished mask ventilation, are you expecting any problems with laryngoscopy?
Due to the defect, laryngoscopy will be difficult and it might injure the palate and it can lodge into the defect. So
it can slip into the defect, yes. So what will you do
lubricated
for that?
gauze can be kept to fill the defect so that...
Okay. Anything else that can be done? Anything else that can be done other than packing the cleft with a gauze? What blade do you usually use?
Miller's straight blade.
Straight. So if you ask me, I routinely use a Macintosh blade. But for this particular case, if I think it might slip into the cleft, I might choose a Miller blade. So just reiterate the fact that you need to have an array of instruments ready. Okay, appropriate sized instruments, tubes, scopes, LMAs, whatever it is, to be used in case you run into trouble. Okay, so straight blade might be helpful in this particular situation. Any other technique of intubation that can be used when you have a cleft and you can't visualize? And
instead of going straight, we can go from the lateral approach.
Use the mic, please.
Instead of going the straight, we can go through the lateral approach. And
what is that called? You're right. You're perfectly right. Yeah. So you can try that paraglossal or the retromolar approach as well. Right. What tube are you planning to use? What tube are you planning to?
RA tube, bring
RA
the
tube. So any problems you can anticipate with this tube?
Tube can be kinked when they place the device on that, and can be misplaced with when the positional changes are happening. The tube
Okay,
may
so
go
what
inside.
what is the position for surgery? For this we are talking about a cleft palate. What position for surgery are we going to assume for the child?
Rose position, ma'am, where the neck is
Head is hyperextended, right? So what can happen with the tube at that point in time?
Tube can go inside, and
When you extend the head, does the tube go inside?
it can accidental extubation can happen.
Accident extubation can occur at this point. When can the tube go endobronchial? At what point?
When they're placing the mouth gag, and
When they open out the mouth gag, that is when it can go endobronchial. So, okay, surgeons have started the procedure, and a few minutes into the procedure, you notice that there's some hypoxia that is happening. So, what could be the possible reasons for this?
tube kinking of the tube can be the
Okay,
primary, or
tube
any
kinking.
disconnection of the circuit,
Disconnection, yes.
or accidental extubation of the tube can happen.
Accidental extubation, yes. At what point does the tube kink?
When they're placing the gag.
Where exactly does it kink?
Which part?
So it can be either at the lip, against the teeth, if the child has teeth, but often you don't have teeth, or it might be deep in. So we need to be careful about that. Anything else that could be causing hypoxia? Can I take 2 more minutes? So you have your demonic, right? What is DOPES? Dislodgement.
Dislodgement, obstruction.
Obstruction. If you have to check your ventilator again. If you're 8 kg baby, you have just set the ventilator and you're giving 200 ml volumes without looking at it, you might cause what? A pneumothorax. That is your P. Equipment failure, you said. And anything else? What is S? So let's look at that. You've given vigorous mask ventilation because your mask ventilation was difficult earlier. What will happen? Anybody? What will happen with vigorous mask ventilation? Stomach distension. So stomach may be distended, especially important in a pediatric baby. The other thing that you need to look for is again your ventilator, see if there's any stacking of breaths that is happening. So that is your S. Okay. Again, the other things that you need to be careful about is postoperative airway obstruction. Some common causes for postoperative airway obstruction, can you tell me?
Airway edema.
Airway edema because of what?
Because of the trickling of the intubation. One is the intubation and one is the...
Unless your intubation is that traumatic, if you've intubated in the first go, do you think airway edema will be there? So airway edema is going to be more at the site of the surgery, right? Anything else?
Tongue edema due to the placement of
Tongue
mouth
edema
gag.
due to the Digman retractor that they use, yes. Anything else? A retained
Trickling
throat
of the
pack.
secretions.
If you have a throat pack, so it's very important that you make sure that your throat pack is accounted for at the beginning and at the end of surgery.
And
then?
Trickling of secretions.
Trickling of secretions. So it could be a laryngospasm for all you know. You need to rule out that as well, right? Anything else you want to add?
So analgesia, how are you going to manage?
Ma'am, blocks can be given like after surgery, post-operatively blocks can be given. For palate surgery, mostly we'll give suprazygomatic maxillary nerve blocks, or we can go for opioid analgesia. Fentanyl can be given 1 microgram per kg, or else pethidine 1 mg per kg, or oxycodone also can be given. Or we can give ketorolac 0.5 mg per kg up to a maximum dose of 30 mg. Or paracetamol suppositories can be given 30 mg per kg. Or IV paracetamol,
Yeah.
if possible also we can.
Just to expand on your multimodal analgesia, you said paracetamol, suppositories. You need to be very careful. Where does the suppository get absorbed?
Venous.
What is that area called? It's at the dentate line, right? Dentate line is really tiny. What is the dose of paracetamol? Suppository?
30 mg
30
per kg.
mg per kg. So if you have a 10 kg child, you'll need to give at least 300 milligrams. So how are you going to give that? You have 80 mg suppository. Will you keep 3 or 4 of that? So suppository is one at a time. If that is not possible, because the otherwise it's going to be rectal. It's not going to be, not going to get absorbed sufficiently. So better than that, I would say, is an IV paracetamol dose. NSAIDs always check with your surgeons, because there is a risk of bleeding that some surgeons are not happy with, especially when it's a palate surgery. Opioids, fentanyl, yes, but for palate, often a long-acting is required. So either nalbuphine or morphine. Codeine is not really, because there are individual variations in the way codeine is metabolized, wide variations, so it's not recommended. Okay? Anything to be added from the audience? Otherwise, we'll close. Thank you.
Thank you, dear speakers and moderators, for such an engaging session. I request the moderators to kindly stay on the dais, and I call upon Dr. Rama Rani to kindly felicitate them. Dr. Rama Rani is the Associate Professor at KMC Manipal.